Good afternoon from sunny Miami. This is Dr. John Bennett, broadcasting for our Neurotrauma online conference taking place today and tomorrow. And today we have the pleasure of having Ariel Estramiana, MD. He's a neurosurgeon from Buenos Aires, Argentina, in the same clinic as Dr. Roberto Herrera, who has given presentations in the past. And first we have a group of 3 global neuro students. We're going to introduce them first before we turn it over to Ariel. Hello, Fred.
Hi guys, my name is Frederick. I'm from Belgium. 50-year student now. Really excited for another amazing hangout.
Great, Fred. Yeah, Fred has an interest in neurology and neurosurgery. And Rakesh, I'm sorry. You're muted, Rakesh. Just unmute. Okay.
Hello. Hi, I'm Dr. Rakesh from India. I'm a neurosurgery resident. I'm glad to be a part of this Hangout team and glad to be a part of this presentation by Dr. Ariel.
Yeah, welcome, Rakesh. And Slaven.
Hello, everyone. My name is Slaven Gorkovic. I'm a medical student at the University of Zagreb in Croatia, and I'm looking forward to this presentation. Thank you.
Welcome, Slaven. Okay, Ariel, could you please introduce yourself, tell where you work and your background before you come into your presentation, and welcome.
Okay, thank you very much, Ron, for this opportunity. And my name is Ariel Estramiana. I work in Buenos Aires, Argentina, as a neurosurgeon, and work in the Adventista Clinic of Belgrano here in Buenos Aires. Well, I'm actually going to start sharing my presentation. And I'm going to talk about traumatic brain injury, especially about cerebral contusion and its treatment. This is the clinic where I work with my neurosurgical team, with Dr. Herrera Roberto, is our chief in charge of the team. And just for begin, let's talk about the epidemiology of this pathology. Actually, in the United States, it's like 100,000 major head trauma occurs, and with a 56% of mortality rate and 55% of brain lesions. Something that's really important to know is that the intrahospital neurological deterioration, it's a sign of bad outcome in this kind of patients. And the hemorrhagic contusion, it's a frequent cause of mortality and disability worldwide. So, which patients go to neurological deterioration in this pathology? Well, we know that elderly patients that has more than 40 years probably go to a neurological deterioration. Also, the patients who, at the moment of the impact and the neurological deterioration, spend like between 6 and 12 hours, there's a 77% of the patients who underwent to neurological deterioration. And those patients who has a neurological deterioration before the 6 hours, now this patient, we need to think that they have another kind of lesions, like extradural hematoma, subdural hematoma. So this is something we need to know and need to assess in all these patients. So the time between the time of impact and the neurological deterioration. So another thing that is real important to know is that patient who had a traumatic subarachnoid hemorrhage, it's more probably than they have an hemorrhagic progression. So for start, let's define contusions. So a contusion is like a brain hematoma, more than 2 cc's, with no contact of the cerebral surface. When we say that, we mean that the pia mater is unharmed. This is actually really important because when the pia mater is harmed, we call this pathology a laceration of the brain. And there's also 2 items that are quite important. There's a necrosis, an hemorrhage, and there's brain parenchymal interposition. So it's different from the intracerebral hematoma, because in this pathology, there's no brain tissue interposed. This occurs in patients with hypertension, diabetes. It's another pathology. So that leaves us with 2 kind of stuff. It's a primary injury for every head trauma at the moment of the impact, and there's a secondary injury that follows the primary lesion. So this is a dynamic process with perivascular hemorrhage, astrocytic edema, macrophage infiltration, and apoptosis. That leads us to a self-regulation alteration and high concentration of glutamate that reduce low cerebral blood flow, and all this process leads to a brain contusion in 3 areas inside the decontusion. Those are the contusional area, the penumbra, and the near penumbra area. So what about the classification? Well, we know that every traumatic vascular injury can be classified in 4 types. The intraparenchymal blood vessels with the contusions, the petechial hemorrhage, the extraparenchymal blood vessels with the subdural hematoma, the extradural hematoma, the pathology with the large arteries in the neck, like thrombosis, dissection, subintimal hemorrhage, and the same things but in the blood vessels of the circle of Willis. So we are talking about the first classification, that are the intraparenchymal blood vessels. Another kind of classification is the one who's associated with some mechanism and some another stuff. Like we have the contusion associated with the skull fracture, with blow below the impact site, or the kickback that occurs in regions far from the impact site, or contusions associated with brain herniations. And we have another kind of pathology, that's the gliding bruises. It's an angular acceleration in gray matter-white matter interface that's called diffuse axonal injury and has actually a real bad outcome. So to see some examples, we have here a CT scan of 2 different patients who had the first one an hemathic contusion. It's hyperdense in the CT scan, and there's a little surrounding area that's hypodense. This is the penumbra area. And then we have on the right another patient with also a contusion, but this kind, it's a mixed contusion. There's several places with focal contusion and cerebral edema. This is another 3 cases with frontal, temporal, and another frontal contusion. This one's bigger with subdural hematoma, some subarachnoid hemorrhage. And this is the first I mentioned, a depressed skull fracture, we can see here, and underneath there's a cerebral contusion. This is also a contusion with more brain swelling, and this is a bitemporal contusion. So we've seen this image before, and this is what we call a burst lobe. It's a hemorrhagic contusion with subdural hematoma. Probably they have also subarachnoid hemorrhage, and there is also intracerebral hemorrhage. And that's important. I don't know if you remember what I said, but in the intracerebral hemorrhage, there is no parenchyma interpose. And in the hemorrhagic contusion, it is. So here, both pathology come together. So that's one important thing. And here are the brain laceration. There's a lineal skull fracture, and we see in the intraoperative photo where we see subarachnoid hemorrhage, all thing red you can see here, and there's a laceration in the pia mater. So we can see brain parenchymal and hemorrhagic contusion underneath. What about the kickback? The kickback is when the lesion is far from the site of the hit. Here, the site of the hit is near this area. So there's an extradural hematoma here, and from the other side, we have subarachnoid hemorrhage and an area of hemorrhagic contusion. Well, this is something that's really important, and it's really easy to do with the CT scan, and it's the volume calculation. Why it's important? It's important actually because it's a prognostic factor. We can decide from this value if the patient needs to go to surgery or or not, and actually it's an outcome prognostic value. So there's a formula that's called the ellipsoid method. So we can measure the anteroposterior length to the lateral and from the height of the hematoma, or the number of cuts in the CT scan in centimeters. And that we divide by 2. That gives us a volume that is like an ellipsoid volume, and we can say that the volume is like 10 centimeters, 20 centimeters, or else. So another thing that's really important is the location of the contusion. So actually it's always in the surface of the brain who can crash against the skull, like the temporal poles, the anterolateral surface of the temporal lobe, the orbitofrontal gyrus, and perisylvian cortex. We can see here an image of a CT scan of a patient who has a lot of hemorrhagic contusion in the frontal lobe, bilateral. See how there are mixed contusions, and this is the cadaveric image. Well, we can see all the area here and here with deep contusion. So another classification can lead us to say that the kind of impact. So we have the first one that's stationary but mobile head. That's when an object impact to a mobile head, like a rock or something else. And the second is the acceleration of the head at the impact. This probably is one of the most frequent. So first of all, in Argentina is the first one, because we have a lot of motorcycle accidents without helmet. So this is one of our greatest mechanism of impact. And then there's a fixed head, like crash. So now we have talked about the contusions, but the contusions have a characteristic that they tend to do a hemorrhagic progression. What's that? Well, that's the emergence of a new hemorrhagic lesion or expansion of an existing one. And that occurs probably almost like in the 25% of the patients, with an incidence from 6 to 67% of those. The 20% of this patient requires surgery, and we do the diagnosis by performing a CT scan. Which are the causes of these things? That's kind of important, because probably there are some coagulopathy that it's clinical or subclinical, molecular change in the penumbra area, and it produces blood flow from microvessels broken by primary lesion. So the hemorrhagic progression has a few factors that are associated with this stuff. And this is the gender. It's very important. We see more often in male than female. The age, as we see, measured than 40 years old. And obviously the coagulopathy. So what happens with the primary injury and the secondary injury? How does it work? How is this pathophysiology? Well, there's a primary injury that produces physical destruction of tissue at the time of impact. And that produces neurons rupture, glia, and microvasculature, with blood extravasation and necrosis that leads us to a toxic and release glutamate. That produces microvasculature dysfunction, who leads us to a secondary injury with excitotoxicity, apoptosis, inflammation, and free radicals. That leads us to an hemorrhagic progression with vasogenic edema, ischemia, and stroke. So we have then a primary impact area with an initial contusion and primary lesion, a penumbra area, and the parapenumbra area. So this, can you see here, a CT scan, the patient at the time of the impact with a cerebral contusion, and the 6 hours progression with a hemorrhagic progression. So what about the molecular changes? Well, the molecular changes are this we can see here in this picture. So there's an impact site that produces nuclear translocation of 2 genes that's called SP1 and NFA-kappa B. That produce an upregulation of a protein that's a SUR1. This protein is a membrane protein, that it's a channel of calcium and allows the cell to incorporate sodium. That leads us to swelling and the capillary fragmentation, with the consequent hemorrhagic progression of the contusion. So there's a lot of things we need to see in this kind of patient, and we need to assess to decide if this patient is or is not surgical, and we are going to do an observatory treatment or surgical treatment. So we need to see the injury type, the location of the hematoma, the volume is really important. The CT scan and the cistern, are they compressed, are they not? How's the midline? There's a midline shift more than 5 millimeters. There's not. This is quite important thing. If there's a perilesional edema, how aged is the patient, the Glasgow scale, if there's hypotension, if there's pupillary reactivity, brainstem reflexes, coagulopathy, we need to see all as one, and it's important to assess every little thing in this point to have a good diagnosis. So, which patients are we going to submit to surgery? Well, the patient with intraparenchymal lesions with signs of neurological impairment, mass effect on CT, or refractory intracranial pressure, these patients are candidates to surgery. Also, the patient with a Glasgow coma scale between 6 and 8 with frontal and temporal contusions more than 20 cc's, or with a midline shift more than 5 millimeters and or compressed basal cistern on the CT scan. Also, a patient with intraparenchymal lesions more than 50 cc's, it's always a surgical because they produce a high intracranial pressure. And something that's really important is that not every hematoma in the brain are surgical. So the patient without neurological involvement and without compression on the CT scan of the basal cistern, this patient, we can do a conservative treatment. So this is a scale, this is Marshall scale for CT scan, who allows us to know the mortality of the patient according to the CT they have. So there's a classification in 4 types. Type 1, it's a normal CT scan, as I say here. Type 2, there's the patient with opal basal cistern, a midline shift less than 5 millimeters. And the 3 and 4 are patients who needs intracranial monitoring and probably surgery, because the number 3, it's a compressed or absent basal cistern. So this is the thing that's really important. That's why we need to see always the CT scan and search for the basal cistern. And then diffuse injury 4, this is totally absent basal cistern. There's a midline shift more than 5 millimeters. This is a sign of poor outcome. And there's high mixed density lesions less than 25 cc's. So what this is like a 1% of mortality to 55% of mortality. So this scale is really easy to use and is really important to know, obviously. So what are we going to do with these patients? So we have a brain contusion patient with abnormal Glasgow. We need always obtain a CT scan. If the patient has a normal Glasgow, so we need to assess for intracranial pressure monitoring and surgical intervention. So these patients actually are really easy to decide to go to surgery because these patients are wrong. So it's not good health. So what about the most hard thing, that is the patient with a good Glasgow of 15 or improves to 15 shortly after admission? Well, we do a CT scan, and there kind of stuff can happen. So there's a little contusion or there's a big one contusion. So if we have a little contusion less than 10 cc's, well, we need to see in the CT scan if the patient has or has not a subdural hematoma or extradural hematoma. So if the one of 2 are present, we need to repeat the scan at 24 hours. Obviously, if the subdural or extradural hematoma are not surgical, no. And if on the CT scan we don't see any subdural or extradural, well, there's no need to repeat the CT scan, and we can observe the patient 24 hours more. What about the greater contusion? Well, if there's more than 10 cc's, we can repeat the scan in 24 hours. because that can lead us to hemorrhagic progression. So if there's an increase in size, we need to assess for surgery. But if the contusion is stable in size, we can do it 1 or 2 days of observation and then discharge the patient from the intensive monitor unit. So we talk about the hemorrhagic progression, the contusion, but what about its treatment, its special treatment, so surgical treatment? Well, we have a tool that's really important to know and is very useful. That's the decompressive craniectomy. The decompressive craniectomy, it was first described by Kocher in 1901. And there's actually 2 techniques. There's an unilateral or bilateral, according to the trauma of the patient. The unilateral is called hemicraniectomy, and the bilateral is called bicoronal. So this decompressive is used always that the patient has an increased intracranial pressure. So if we have an increased intracranial pressure, once exhausted the neurointensive medical treatment, we can do it. Or if the intracranial pressure is elevated above 25 to 30, with a cerebral blood pressure about 18, or patient with Glasgow from 5 to 8, with an ICP opening between 25 and 30, or this is the letters from Marshall scale, 3 or 4. Those patients are surgical with this decompressive. And also the patient with greater than 30 of intracranial pressure and a bad Glasgow, those patients are real favorable with an early decompression. That's really important. So what's the surgical technique? Well, we do, as we call, a trauma flap incision. This is the incision that we can see here. So there's like a question mark or a C shape. And it extends from the midline here, at least 2/3 from the posterior part of the temporal and parietal lobe, finishing ahead the internal auditory channel. And it's important to end 1 centimeter in front of the auditory channel, because here it goes the superficial temporary artery, and we need to unharm it. So we made 6 to 8 burr holes, like we see in this dot, in these black dots. And something that's really important, it's a tip you need to know, is when we do the burr holes, don't do it too close to the midline, because beneath this is the superior sagittal sinus, and we can damage it, and there's a lot of bleeding from there. So be careful with the midline. And another thing that's really important is a good decompression of the temporal bone in the anterior and inferior part, because I've seen a lot of decompressive. They have a lot of frontal, parietal, temporal bone decompression, but not the pole of the temporal lobe. And this is the most important thing in this kind of craniectomy. So after we remove the bone, we make a dural opening, like a C shape or question mark again, and evacuate the hematoma. This is the simple part, actually. And for the closure, we may or may not do a dural closure with soft tissue as gallia or pericranium for sealing that. This is an example of a decompressive craniotomy I've made in my hospital, and we can see here how the medium fossa is totally decompressed. You can see here's bone and here's no bone here. This is the most important thing is to decompress the medium fossa. And actually, there's another thing that's important. It's the length of the craniectomy. From here to here, it must be like 14 centimeters. That's the cut. And watch out always the midline. Here's kind of lot, so probably until here will be better. This is an example of another decompressive craniectomy that we see here, and that's actually real big, and probably the patient improved his intracranial pressure, but the problem is that it's not good enough. So this part and this part are the most important thing. So probably this seems to be a very huge decompressive, but it's not. It's not important to go so back here, so it's really important to decompress the temporal pole. The another decompressive craniectomy is the bicoronal decompressive. We made a bicoronal incision from internal auditory channel from one side to the contralateral side. And here it's important to preserve the midline, because what we have seen here, because there is this longitudinal, the sagittal sinus, and another thing that's really important is for the reconstruction later. We need to know that we need to reconstruct this patient after surgery. So this is important. We make 6 to 7 burr holes each side. It's like the other technique, but both sides. And we can see here an image of a patient who had a bicoronal decompressive, but there's a lot of things we can see here that's wrong. First, there's no temporal bone and parietal bone removed. It's only actually a partial decompressive. There's no the bone in the midline. That's another problem. This is at the time of the surgery. We can see there's a dura mater retraction and also skin retraction. So once we put the prosthesis inside, it's real hard to close the skin to approximate the dura mater. So there's a lot of problem with this technique if you made like this. So the dural opening is a C shape or a question mark like the other, and the dural closure is like the same thing. What about the complication of this procedure? Well, we have seen like 7% of infection, a 4% of CSF fistula, and 3% of subdural hygromas. Well, to go for the end is we have some clinical cases to see what we have done with this patient and how they went. So this is the first one. It's a patient of 61 years old, male, with 48 hours of evolution of head trauma. This is a patient with a motorcycle without helmet. And the patient came with 8 of Glasgow and anisocoria. Obviously, a right anisocoria. So we can see a lot of cut, the sagittal, coronal, and axial cut of the CT scan, where we can see the contusion, a real big one contusion. It's like 50 centimeters cubic, and there's a penumbra area. There's some blood inside the ventricle. This is the midline. We can see the midline should go this way, and it's like this way. So there's a shift more than 5 millimeters. And another thing that I was talking was the basal cistern. We can see there's no basal cistern, no Sylvian cistern. So this is a patient with a Marshall scale of 4 and a huge hematoma. So the patient underwent to an unilateral decompressive. We can see the 40 centimeters here in the bone, and there's still some bleeding inside the surgical area. That was because the patient has a coagulopathy that was real hard to treat. Oh, another thing that's really important, look the post-op CT scan, and we can see the midline back in the normal place. This is another case we had. It's a patient, it's a male, like 40 years old, and this is the CT scan we perform in the hospital. So when we see this patient has had 40 of Glasgow, subdural hematoma, some suranoid hemorrhage, and there was a little contusion here. But the patient was real good, so we just expect them. We repeat the CT scan at 24 hours and 48 hours. In the 48 hours CT scan, we can see these things. So the patient developed a bilateral contusion of the temporal pole and a perisylvian contusion real big. So this patient, because they had of both eyes with contusions, underneath both eyes of the temporal poles, we do an evacuation and decompressive craniectomy of both sides. Actually, this decompressive is quite short here, and there's some removal of bone here that must be removed, but it's a good example for bilateral decompressive. So we can see the both temporal contusions, and the pericerebral one. So to end some of everything I was talking, so in conclusion, the hemorrhagic contusion progression of these patients occurs approximately in the 50% of the patients, and the 20% require surgery. Always remember that in between the 6 and 12 hours post-trauma, for molecular mechanism occurs the hemorrhagic contusion progression. So this is very important not to discharge this patient from the hospital. Probably if we see a little contusion, less than 1 centimeter, and the patient is with good neurological behavior and else, don't discharge from the hospital because there's a lot of patients with hemorrhagic progression. The inpatient neurological impairment correlates with poor outcome. This is really important. The patient who arrives at the hospital in bad shape, this is real poor outcome. And another thing is important, that the patient with brain contusion less than 10 millimeters with good Glasgow scale in the first 48 hours has low probability of hemorrhagic progression. And another thing that's important, that elderly patient with large brain contusions, Glasgow less than 50, and associated with subdural hematoma, subarachnoid hemorrhage, they had high probability of hemorrhagic contusion progression. And this patient has a poor outcome. Remember that always the brain has a lesion. The brain doesn't recover as good as in pediatric patients. So elderly patient has real bad recovery and real bad outcome over this pathology. And another thing that's important to know, it's the decompressive craniotomy. It's a safe procedure and improve the outcome in a major head trauma. And it's really easy to do it, and it's a technique that every neurosurgeon must know and must practice to perform. And it's really a great surgical tool because the patient actually improves a lot with this procedure. So it's really important to diminish the intracranial pressure in every head trauma. Those is a minor head trauma, a major head trauma, a subdural hematoma, a contusion, or a diffuse axonal injury. So the decompressive craniotomy is the most important thing a neurosurgeon must do in every watch. So it's really important to know this technique. So that's all.
Very good, Ariel. Thank you very much for having the courage to try this new platform, and I hope to see you many more times. We'll turn it over to Rakesh first, since he's a neurosurgeon on the panel. Rakesh, are you there? Do you have any questions? You want to start things off?
Yeah, hi, Dr. Ariel. That was a very nice presentation, by the way.
Thanks.
I saw a few cases that you presented. Decompressive craniectomy. You were telling about the size of bone to be removed. So is that any standard of the size that you have to be removed, or is there a range of centimeters that you have to remove?
Yes, it's important the length of the craniectomy from anterior to posterior side margin of bone. It's 14 centimeters. It's okay. Important. The point of cut.
Okay. Okay. It was a nice presentation, and that's all I have.
Thanks.
I guess it's a pretty basic procedure, the decompressive craniectomy. That's one of the first things you learn as a neurosurgeon, Ariel?
Yes, it's one of the first things we learn, and it's actually one of the most important things we know, because every patient who has an intracranial pressure that's high is an urgency, and we need to perform this procedure, the decompressive craniotomy.
Okay. One question I have as a non-neurosurgeon, it seems that this kind of problem depends a lot on CT, both monitoring, diagnosing, etc. Have you noticed any improvements in CT since you first started practicing as a neurosurgeon, or is it pretty well the same?
No, actually we have now at the hospital and the clinic, we have a multi-slice CT scan that's faster. We can do reconstruction and it's also pretty much amazing for this. We can do a full body CT scan in like 30 seconds. So
Really? 30 seconds?
yes,
Wow.
yes, it's real fast. So when the patient had a polytrauma in the street, we can perform a full body CT scan very quickly, and if the patient has something neurological, we need surgery, we can go to the OR and do the surgery real fast.
Well, you know, I guess I'm pretty old because back when I was in the emergency room, that was one of the big holdups. You know, you have to send the patient to neurosurgery. You have to send a doctor sometimes to go with them to the suite. So they had the CT, and it would be like an hour after the patient presented to the emergency room. That's a huge improvement.
Yes, that's actually is really important. And also with the MRI now is like 3 Tesla. It's really improved the quality of the image, but the problem with the MRI is that for this kind of patient, it takes a lot of time, probably 40 minutes to do a CT in a brain scan.
And by the way, Roberto is watching. You can say hi to Roberto. Okay, Slaven, I'm sure you have some questions.
Yes, of course. Well, thank you. This was a very interesting presentation about a topic that is always complicated and always around, I think, in neurosurgery. And I was very interested in the case that you presented, the one that had those that looked like a fracture of the frontal skull. So what was that? I mean, there were no frontal lobes there. How could this happen in a patient? Can you please describe a little bit more about this? Because it was so interesting. I've never seen something like that.
Okay, actually, sorry. Actually, they have both frontal lobes. This patient with the bicoronal decompressive, but when the patient don't have the bones in the frontal area, that occurs. There's a cerebral retraction and a dural retraction, so it seems like there's no frontal lobe. That patient also is a motorcycle accident without helmet, and then there was made a decompressive craniectomy in another hospital that was not good enough, so the patient actually has a real bad outcome and a bad neurological status.
Yes, I understand. There was an interesting presentation by Dr. Cole on the last conference that we had on brain tumors, and she presented the hinge craniectomy. This is a project that she's doing. So how many experiences do you have with this kind of craniectomies?
Well, actually, we have between the clinic and our hospital like 700 surgery per year, and 50% are trauma. So actually, we have a lot of this in our hospital. We made a paper with this presentation of all the patients. We have like 300 patients present, and actually, it's something we perform every week, 1 or 2.
Impressive. Thank you very much. You can tell the experience in your presentation. Thank you.
You know, one question I have, Ariel, is that I know with the eyeball, when you get a direct blow or contusion, it looks terrible, but frequently, if it doesn't affect the vision, it's a conservative type of treatment. You just wait till the contusion clears up, and the bleeding in the eye just goes away, as long as it doesn't affect, you know, the vital structures of the eye. It seems like it's pretty similar with cerebral contusions, where you just kind of you monitor the neural status. It may look bad because there's blood around the brain, but it's frequently resorbed. Is it resorbed, or are you really aggressive in wanting to go in there and taking out, or is it strictly monitoring the neural status, and that determines your course?
No, actually, it's like you say, it's not. We don't need to rush about this, and we monitoring the patient. If the patient have a neurological impairment or a bad Glasgow Coma scale or deterioration, well, that patient go to surgery. But if not, we can control the patient, and it's like the 20% of this patient require surgery. So there's an 80% of the patient who doesn't underwent to surgery. So that's an important concept.
Right. So just basically monitor and watch closely.
Yes.
Do you give any medications? Do you give steroids or anything to decrease the pressure, or no?
No, actually, for the head trauma, there's a lot of paper published that said that the steroids are now useful for this.
No longer useful.
No. It's had actually the patient who underwent to steroid had a poor outcome. So that's why we don't use it.
Okay.
So probably some mannitol or some sodium hypertonic. That probably yes, but no steroids.
Okay. It's the same in India, Rakesh?
It's the same in India. The studies have proved that steroids are not useful for head trauma. Yes, they are useful for a spinal trauma, if I'm right, Dr. Ariel. Yeah,
Yes.
they are now more useful in head trauma.
Okay. Very good. Fred, do you have any questions at all or remarks?
No, not really. I had the same question as Slaven, but yeah, that's resolved. So, but it was a really nice presentation. So thank you for that.
Yeah, very clear. Yeah, I would like to thank you, Ariel, for spending the time and to experimenting with this type of platform of Google Hangouts. And we look forward to working with both you and Roberto in the future.
Okay, thank you very much, Sean, for can do this from this platform. That's real great, and for meeting all the neurosurgeons from all around the world. It's quite amazing. So thank you very much for this opportunity.
Thank you very much.
There'll be lots more. And thank you, everyone on the panel.
Thank you, Ariel. That was a nice presentation. Thank you, everyone.
Thank you.